Evening, everybody. It's exactly 5 o'clock in the evening, and we're going to be starting our webinar today. My name is Dr. Aashish Contractor, and I'm the head of Department of Rehabilitation and Sports Medicine at the Sir H.N. Reliance Foundation Hospital in Mumbai. So welcome from Mumbai. I'm also the Vice Chair of the International Council of Cardiovascular Prevention and Rehabilitation. Firstly, a great thank you to USV and the team for getting this together. They've been talking to me for several days, and many of them are in the room as we speak to help in the technical things. And is everything okay? Yeah. All right. Okay. So today, what we're going to talk about is what is cardiac rehabilitation, what is secondary prevention, and how we're going to implement it in our daily lives. And it's significant to talk about it today because it's World Heart Day. 29th September every year is World Heart Day. And we have an hour schedule for this. So what I'm going to do is I'm going to keep a strict watch on my clock out here. I'll probably talk for about 25 to 30 minutes. And then all the questions that you have, you can ask them later, or you can sort of type them in right now so that we can have it on the screen and try and answer them later. Okay, so let's get going on this. This is just a picture of the room that we're sitting in. So this is the Sir H.N. Reliance Foundation Hospital. It's an old heritage hospital which is 90 years old, and it's been revamped recently. So the back tall building is the tower building where the patient rooms are, and the front heritage building on the third floor is where I'm sitting, where the whole floor is our rehabilitation and sports medicine department. So why are we talking on this subject? The screen that you see now, the map that you see, is the WHO map showing the prevalence of cardiovascular disease across the world. And you don't need to look into the numbers, but just look at the colors. The colors which are red show the highest prevalence of cardiovascular disease. And unfortunately, as you can see, India is squarely in the red out here. This is for men, and this is the picture for women. So for women, it's just a little better. It's not red, but it's orange. So heart disease and cardiovascular disease, as you probably know, is the leading cause of death in our country, not only in men, but in women as well. It's a misconception that heart disease is a man's disease. All our male patients joke with us that the ladies give us heart disease, that's why they don't get it, on a lighter note. But that's not true. Heart disease, as I say, is an equal opportunity killer. In other words, men and women suffer equally. It's just that women tend to suffer a little bit later in life, typically after menopause. So this is not only the leading cause of death in men and women in the country, even in urban as well as in rural areas. So that's important to keep in mind. So in the outline today, we're going to talk a little bit about what is cardiac rehabilitation. We'll talk about some of the benefits of cardiac rehabilitation for secondary prevention of cardiovascular disease. We're going to be talking about some novel methods for implementation of this in your daily practice. And then we'll end with the conclusions and question and answer session. So in terms of what is cardiac rehabilitation, if we want to look at a formal definition, basically these are services which are comprehensive, long-term programs involving the evaluation of the patient, to use exercise, cardiac risk modification, education, as well as counseling. And why are we doing it? We are doing it to limit the physiological and psychological effects of the disease. We want to, of course, reduce the risk of sudden death, reduce the risk of reinfarction, looking at controlling cardiac symptoms, and basically trying to stabilize or even frankly reverse the atherosclerotic process. So the simple two-point aim of the program, and this is what I tell patients when they come in, instead of giving a long definition, we do two things in the program. The first is to help the patient recover and get back to their normal self quickly and safely, whatever their normal was. Often the normal is not at a very high level, but whatever it was, we help them get back to it as quickly and safely as possible. Second, and more importantly, to implement long-lasting lifestyle changes to make sure that we reduce their long-term risk of heart disease. Because clearly, once somebody has suffered, they do not want to suffer a second time, which is essentially what we call secondary prevention. And in our country today, we really need to institute both primary and secondary prevention because unfortunately we are undergoing this epidemic of cardiovascular disease. So in terms of indications, who is eligible? Frankly, one simple line is anybody who's had any form of heart disease. So whether it's MI, whether it's a bypass surgery, whether it's somebody with stable angina, with heart valve problems, somebody with an angioplasty, somebody who's had a heart transplantation. We are seeing more and more of them happening in our country. Somebody with chronic heart failure. A lot of times, the patient will survive thanks to advanced care, but eventually at some point might get heart failure. So we need to also take care of patients who have heart failure. In terms of who is the rehab team, so the person at the center of the rehab team, and frankly at the center of everything we do in medicine, is the patient and the family member. In addition, you have the family physician, the cardiologist, the surgeon, the rehab physician, you have a physical therapist involved, you will have a nutritionist, if you have yoga, you've got a yoga therapist. So it's a complete team effort. And honestly, it works best if the team talks to each other and remember, always keeps the patient and the family at the center of all the care and attention that they give. If we talk about how to deliver it in a practical manner, there are essentially two important phases. Phase one is when the person or the patient is in the hospital. So in early days, actually, if you read maybe even 60 or 70 years back, when a person had a heart attack, they would simply ask them to have complete bed rest for even 3 weeks, 4 weeks, 5 weeks. Today, we know that's changed. Complete bed rest is detrimental, frankly, for everyone. Nobody should have complete bed rest unless they've broken a bone or they're immobile for some reason. So the moment the patient is a little bit stabilized, even in the ICU, we start their mobilization. We try and mobilize them at least twice a day. Some patient maybe even 3 times or 4 times in the day. We progress their activity as they stay in the hospital. So the first day may be just sitting upright in the bed. Then you would move from bed to chair, chair to standing, standing to taking the first few steps, and then walking maybe 5 minutes, 2-3 times a day. So before the patient leaves the hospital, in most cases, in most uncomplicated cases, they ought to be able to walk for about 5 minutes, 2 or 3 times a day. In terms of precaution, when you're monitoring the patient, if they've got arrhythmias, now of course, cardiac patients often have isolated premature ventricular contractions, so that's not something you'd worry about. But if you have runs of ventricular tachycardia, if the patient's got atrial fibrillation, if they're unstable because of the arrhythmias, clearly we would keep that very much in mind and try and monitor them while we mobilize them. Patients with low ejection fraction. And let me add a word about ejection fraction. Often doctors worry, how should I put it, a little bit too much on just ejection fraction as a number. And today we know that just the ejection fraction is not necessarily the best prognostic indicator of how well a person can do physically. So you might have somebody with an ejection fraction of 35 and they could do everything. So just because their ejection fraction is low does not mean you should completely restrict their activities. It just means that you need to be a little more alert, you need to be a little more careful about it. That was phase one, where the patient is in hospital. It's also a great opportunity to educate the patient, because ultimately, if you want to try and reduce any future risk of chronic disease, you need to educate the patient on what they need to do to take care to avoid this in the future. When we talk about phase two, this is outpatient. So the patient has gone home, and depending on his condition, within 2 to 3 days, say in an uncomplicated angioplasty, maybe 2 weeks later after a bypass surgery, maybe 10 days later after an myocardial infarction, the person comes in and we do what's called outpatient cardiac rehabilitation. In this, what we do is we actually make the patient exercise in our presence, in our area. Let me show you this. If you can see, this is a small piece of equipment. It's a telemetry monitor. So to this, we attach the ECG electrodes. We attach these leads. And then, because it's so small and light, it's a little bit bigger than a cell phone, the patient can move around everywhere. And then on our computer screen, so in my case, I've got a system where it comes wirelessly even on my iPad. So wherever I am, we can actually monitor the patient live, monitor the patient real time while they're exercising. We can look at all their parameters. So aggressive risk factor modification is a very important aspect of what we do. Educating the family, because ultimately the patients don't live in an isolated environment. They live in a family environment. So we need to take care of that as well. And the patient usually comes in 2 or 3 times a week. This is in a hospital, in a full-fledged rehab center. Later on, we can talk about what you can do in your daily practice as well. In terms of what are the benefits of cardiac rehab for secondary prevention, let's first look at what are the risk factors that we're preventing. So the Interheart study clearly explained that 90% of all coronary heart disease risk can be attributed or explained to 9 major risk factors. Smoking and tobacco consumption, dyslipidemia. We again know that in the Indian population, it's common to have a low HDL level, a high triglyceride level, high blood pressure, diabetes, abdominal obesity, psychosocial factors, stress, anxiety, hostility, depression, fruits and vegetables, so low fruits and vegetable consumption. Exercise, or rather lack of exercise, is a very, very important risk factor in our country, and alcohol consumption. So all of you are leading physicians, leading cardiologists. So can you imagine if the pharmaceutical agencies came out with a drug which could reduce the risk of heart disease by 40%? Lower the risk of patient having stroke by 27%, diabetes by 50%. So between heart disease, stroke, and diabetes, most of our chronic deaths take place, don't they? High blood pressure by about 50%. Mortality and risk of recurrent breast cancer by that much. Colon cancer and Alzheimer's. So can you guess what the price of such a drug would be when it becomes available in the market? Well, this is how much it costs, okay? So you probably guessed right as I was going through the numbers. The exercise is known to cause all those lovely effects. And these are all data from published big studies, meta-analysis across the world. It's not just numbers that are made up for this presentation on World Heart Day. So with exercise, you can get all these benefits, and all you need are a pair of shoes. For those of you in the audience who are runners, and I hope many of you are runners, you know that today the trend, or the fashion, is to actually go barefoot running. So I joke with my patients that now you don't even need this to get the benefit. All you need is this, a pair of legs, and most important, a good strong heart. And on a serious note, you don't even need this. Can you have a look at this picture? You see the red circle out here? This gentleman is wearing a prosthesis and he's running. So earlier I said you need shoes. Then I said you don't need shoes, you just need your feet. He doesn't even have his natural feet. He's got a prosthesis. This is actually a picture of a close friend of mine. His name is Major D.P. Singh. And let me quickly, since we got time, let me tell you the story of Major D.P. Singh. This is the Major when he was 25 years old in 1999. This picture was taken in Kargil. He was at the forefront. He was on the front line fighting the war when a bomb burst near him. When that happened, he was immediately taken to hospital. And after the first couple of days, his legs needed to be amputated to save the rest of his body because he had developed gangrene. He was in hospital for an entire year. I asked Major, what all happened? He said, Doc, it'll be easier for me to tell you what has not happened. So he sent me the slide. This Major D.P. Singh himself sent. So pretty much he had something from head to toe from hearing loss to spondylosis to amputation. At the end of a year, he weighed 28 kilos. This is otherwise a healthy man, approximately 5 feet 8 inches in height. He weighed 28 kilos. He was in his hospital bed, completely depressed. This is Major DP Singh's X-ray now, today. When I say today, I mean a few months ago. So you can see next to these red lines, all these white sort of dots, it looks like snowflakes. This, as you would have guessed correctly, is shrapnel, which is still embedded in his body. Now, you would imagine somebody like this, who's had a problem from head to toe, would just be satisfied if they could just walk a little bit. But not Major DP Singh. He resolved after 1 year that after he gets out of hospital, he will not have self-pity. He's going to go on and not only walk, he actually started running a few steps. And now every year he runs at least 10 to 12 half marathons throughout the country. What's more creditable is not only that he's doing it, he's inspired others to do it. This is his group. It's called the Challenging Ones. So all these people, including this little child out here, they've got prosthetic legs. Some have got one prosthetic leg and some have got two. And they call themselves the Challenging Ones. And they actually train and they run from marathon to marathon in different cities, inspiring other people and showing them the right way and giving them hope. So this, my friend, is the benefits and the power of exercise. Okay. So getting back to cardiac rehab versus usual care, since this is a scientific seminar, let's talk a little bit about numbers. So when they compared cardiac rehab with usual care, looking at a meta-analysis, they found that cardiac rehab reduced mortality by 20%, cardiac mortality by 26%, non-fatal MI by 21%, future risk of having a surgery by 13%, and angioplasty by 19%. So clearly, very impressive numbers out here. Let me present you just one or two more studies. This one is looking at 600,000, 6 lakh US Medicare beneficiaries. And I'll just sum it up for you. I won't go through the whole study in detail. Essentially what they found, to just sum it up, that those users or those Medicare beneficiaries who underwent cardiac rehab, they had relative risk reductions of about 34% compared to those who did not undergo cardiac rehab. And again, those who did more than 25 sessions of cardiac rehab had a much lower risk compared to those who did fewer sessions. Another one, again, this is a US-based study looking at those who had coronary artery bypass surgery between 1996 and 2007. There were 846 patients who survived at least 6 months after surgery, and they found that about 69% of them had attended cardiac rehab. And this is what they found, that cardiac rehab attendance is associated with a significant reduction in 10-year all-cause mortality after bypass surgery. So somebody did rehab only for 3 months, but even 10 years down the line, those effects were still there, and they reduced risk in the long run. So therefore, their results strongly support national standards that recommend cardiac rehab for this patient group. So now let's talk about how to implement. What are the practical ways that we can implement this in daily practice? So this is an article in circulation. This was a position statement of the American Heart Association, American College of Cardiology Foundation. And basically this is the name of the position statement is Secondary Prevention and Risk Reduction Therapy for Patients with Coronary and Other Atherosclerotic Vascular Disease in 2011. And this is the guideline again from the American Heart Association and the American College of Cardiology Foundation. And this is what I want to point out here. On page 2, when they talk about cardiac rehab, it's a class 1A recommendation. Now, doctors, all of you know that a class 1A recommendation is the highest level of scientific recommendation. So things like giving a daily aspirin to people with coronary artery disease. So cardiac rehab comes under that same category. So therefore, in your practice, it's absolutely essential that you implement cardiac rehabilitation and secondary prevention. How you do it in each practice, in each setting, it might be different. But the fact is that it needs to be done. In fact, I I'm part of the ICCPR, which is the International Council of Cardiovascular Prevention and Rehabilitation. And I should have made this slide, but it's not there on my screen at the moment, where we wrote a consensus statement, which was published in Heart, talking about methods of implementation of cardiac rehab in low and middle income countries. So I'll ask the USV team to share that paper with you, but that is looking at how to do cardiac rehab in a low resource setting. So let me just show you some pictures of what we do at our hospital. This is our rehab area. This is the computer where we monitor it. This is me sitting with my iPad. And for the sake of this picture, I was sitting here, but usually I'm in my consulting room and my staff is out here and the patients are exercising on various pieces of equipment. They may be walking on a treadmill. They may be on a cross trainer, on a cycle. And over time, we start very slowly. We start with them walking just 5 minutes. And the 5 minutes becomes 10, and the 10 becomes 15. And we slowly build it up over time. In fact, today you'll be happy to know that several of our patients, when I say several, I mean at least 25 of my patients in the past, they run marathons every year. And again, I keep saying they run marathons, not to say that if you had heart disease, you have to run a marathon. No, not by any means. But the point I'm trying to make is that even though they've had heart disease, they've actually turned their life around by attending regular cardiac rehab and then taking it to the next level to do what most, how shall I say, ordinary or so-called ordinary healthy people are not able to do. And their average age is about 55, 60, 65, and they've all had a bypass surgery or an angioplasty. And many of them have been doing now, they've done 30, 40, 50 marathons as well. Part of training is also strength training. So it's a misconception that people with heart disease, people with high blood pressure shouldn't strength train. And when you strength train, you don't have to have fancy gym equipment or you don't have to bodybuild to try and look like some movie actor. The idea of strength training is to maintain your muscle mass. Because as you age, there is loss of muscle mass and we need to try and maintain the muscle mass for good health as well as for activities of daily living. So you don't need muscle mass just to sort of look good. You need muscle mass to carry a 5-kilo grocery bag. You need muscle mass to carry a 7 or 8-kilo bag, your travel bag when you're traveling by plane or by train. So in terms of what you need to do, you can use a band exercise. This gentleman in this picture in the center out here is using what are called TheraBands. He's using light hand weights. This lady is using light hand weights. If you're in a setting where you want people to exercise at home, just give them a bottle of water, tell them to fill it up, that becomes a 1 kilogram weight. So you can be innovative, you can work out within the limitations that you have to make sure that you implement these guidelines. Let me spend a minute talking on the cardiovascular benefits of exercise from a scientific perspective. And this is a slide which is shared with me by Dr. Barry Franklin. He's one of the leading gurus in the world, and he's there on the most position statements. He always says that cardiovascular benefits of exercise can be put into 4 categories. First is the anti-atherosclerotic effects, right? Things like improving the lipid profile, lowering blood pressure, reducing body fat, reducing adiposity, increasing insulin sensitivity. More and more we know that heart disease is a disease of insulin resistance, disease of inflammation. So we know that cardiovascular exercise or exercise reduces the risk of both inflammation and improves your insulin sensitivity. Second are the anti-ischemic effects. It decreases your myocardial oxygen demand, increases coronary blood flow, it decreases endothelial function. You know that endothelial function is one of the main problems because of which the process of atherosclerosis starts. Then are the anti-thrombotic effects. We know that when there is a plaque, the plaque tends to rupture and a thrombus forms at the site of rupture. So with regular exercise, you decrease the adhesiveness, the stickiness of the platelets. You increase fibrinolysis, you make the blood thinner, a sort of like a blood thinner effect. You decrease fibrinogen, you decrease blood viscosity. And lastly are the anti-arrhythmic effects. With regular exercise, your vagal tone increases. So your risk of sudden cardiac death with arrhythmias becomes much lower. It also decreases your adrenergic activities. If adrenergic activity is high all the time, that's also going to put you at a higher risk. So just to reiterate, the four areas of cardiovascular benefits of exercise will be anti-atherosclerotic, anti-ischemic, anti-thrombotic, and anti-arrhythmic. We use yoga as part of what we do. Whenever I address a seminar, people ask me, Doctor, can I walk, or can I do yoga instead of walking? And I tell them, you certainly should and can do yoga, but the benefits are different. So I think the benefits of regular cardiovascular type walking, cycling, swimming are different, and the benefits of yoga are different, and they complement each other. Remember also that yoga is a way of life, not just doing asanas. So it's your ahar, vihar, vichar, how you lead your life, the diet you eat, the reduction in stress, the meditation, having faith, being spiritual, all of that helps. So to answer your question before you even ask it, yoga is beneficial for health. I don't think it should be a yoga or exercise type of decision. You can have both. And all our patients undergo yoga as well. This is a picture of our hospital staff, the nurses, undergoing yoga on World Yoga Day this year. Just going to end my sort of formal part of the presentation with just showing you around a little bit in our department. This is a water treadmill. This is for patients who've got joint difficulties or not able to walk on land. So they get into water and they walk, which is much kinder of the joints, good for patients with obesity, good for patients very deconditioned, some patients with neurological problems. This is a similar picture of the water treadmill. So this is in the cardiac rehab center at the hospital. What about home-based? So today there's technology. So this picture, this little piece of monitoring equipment, as you can see, it's smaller than a cell phone. And the wires come and you hook up the person. And this monitor actually talks or is attached to your cellular phone. And from the patient's cellular phone, this can be transmitted to your phone or frankly to any phone in the world as long as there is a Wi-Fi or a 3G, 4G connection. So you can also monitor people in a home-based program. So this is how it looks. This is the ECG running real time on the screen. And this technology is available in our country as well. And frankly, it's not too expensive. We have fitness center-based rehab. So this young trainer is wearing this strap, and below the strap out here are sensors, and the sensors detect the ECG, and you can see this is the reading. It gives you a summary. What's the average heart rate, the heart rate max, the calories burned, and a single lead ECG. Okay, now a single lead ECG may not be best for detecting ST segment changes, but certainly for arrhythmia detection, for heart rate monitoring, it is extremely effective. Okay, so now let's come to the conclusions. What have we seen from all that we have spoken about? So we know that cardiac rehab is an essential part of secondary prevention for cardiovascular disease. Again, I want to recommend, or rather I want to emphasize that it's a 1A recommendation. So the benefits have been clearly proven in several well-controlled, randomized controlled trials. So you need to recommend it to your patient. Cardiac rehab programs, as we saw, they're shown to have a significant impact, a significant reduction in both cardiac as well as all-cause mortality. The benefits of cardiac rehab also include greater patient adherence to lifestyle modification and risk factor reduction. So the monitoring aspect, now this is something which sometimes the cardiologists tend to overlook. Let me give you an example. Often in your busy practices, you will see a patient today and you will take a blood pressure. And based on that blood pressure reading, you will alter the person's medicine. But we know there is white coat hypertension, there's all sorts of differences in pressure. So that one reading that is taken in the clinic will decide what happens to the patient typically for the next 3 or 6 months. On the other hand, when they come into a program, when they're monitored regularly, they come to us 3 times a week. We take resting pressure, we take exercise pressure, we take pressure after exercise. So we can get a nice chart as to what's the true pressure or the true sugar of this individual. And working in collaboration with the cardiologist, with the diabetologist, we can titrate our care. So typically patients' adherence to therapy increases a lot when they come into such programs because there is that sense of accountability. It's also a question of monitoring. So if a patient may feel fine when they come to you, but they tell you, you know what, doc, last night when I was walking, taking a light walk after dinner, I was feeling this heaviness. After walking for 5 minutes, it came on, I sat down, I felt better. And I've been feeling that way for the past few days. So in a rehab program, they could give you that sort of feedback because you're in touch with them very closely. In terms of implementation, yes, it would be nice if it's there in your hospital, you have all the advanced equipment, but frankly, you could do it at a home-based program, you could do it in a clinic-based program, it could be a fitness center-based program. But the important aspect is you need to monitor the individual's risk factors and make sure that they come under control. Once that is done, your risk, or rather their risk for cardiovascular disease, is going to come down tremendously. So last couple of slides, let me take this chance to just talk a few seconds on my book. My book is called The Hard Truth. All that I've spoken is part of it. It's titled The Hard Truth, Everything You Wanted to Know About Prevention, Treatment, and Reversal of Heart Disease. It's available on Amazon.in as well as some bookshops. So once again, it's called The Hard Truth. And I'll just end with pictures from this morning. So 7 o'clock this morning, we had a World Heart Day run. We had 500 people, and there were more, but we capped it off at 500 taking part from the hospital staff. This is the staff in our department, the doctors, nurses, therapists, and this is a picture with the patients. These are all the patients I was talking about. Frankly, and I mean this honestly, most of our group of regular patients ran longer. They did the 8 kilometers versus the 4 kilometers compared to hospital staff. Not only did they run longer, they actually ran at a faster pace as well. But the bottom line message is that heart disease is not the end of life for a patient. It ought to be the beginning of a new life. Because frankly, all these patients, most of them had never run ever in their life. The average Indian, once they've frankly past the age of 18, 20, is really not into that much exercise or into running or fitness. So they did not start running in spite of or despite having heart disease. They started running because having heart disease. And today they're better than before. So I think that's something which you as doctors, as cardiologists need to also adopt as role models. So thank you very much for your attention. Thank you for being here on a Friday evening. I know it's the beginning of a very long weekend. Tomorrow is Dussehra. So happy Dussehra. And I'm very happy to answer your questions. It's 5:35, so I think we've kept to time. And I'm very happy to spend the next 25 minutes answering your questions. So please do post the questions. Thank you.
Hello, doctor.
Yes. Hello.
Thank you for the wonderful presentation. We have gathered the questions. I'll ask you one by one.
Sure.
The first question is, ideal time to start CR after an ACS?
Okay. So if you know the name of the person and where they're from who asked the question, that will also be helpful. If you don't, that's fine.
It was asked by Mr. Alok Rai.
Okay. So Dr. Alok, the ideal time to start cardiac rehab after an ACS, an acute coronary syndrome. So let's divide it into 2 or 3 sections. So if somebody's had an angioplasty, and there weren't too many complications, there wasn't a myocardial infarction just before it, I would say you can start a gentle program as early as within 3-4 days after an uncomplicated angioplasty. After a bypass surgery, once the patient is stable and they go home, maybe a week after they come back. So typically 2 weeks after surgery. So 1 week they're in hospital, 1 week they're home, and then they come back. If somebody's had a myocardial infarction, I would say once they're stabilized, they're home, maybe 5 or 7 days later. Now, somebody may have had a myocardial infarction and their ejection fraction may be 20%, and somebody may have had a myocardial infarction and the ejection fraction may still be 45-50%. So how aggressive you are once they come in will also depend on what their profile is. But getting them started, you could start within a week or 7 or 10 days of going home.
Okay, doctor. The second question is by Mr. Manu Shukla. And the question is there any cardiovascular benefit of leisure walking as compared with brisk walk?
Okay, that's an interesting question. The question is there any benefit of leisurely walking as compared to brisk walking? So let's divide physical activity into two components. What is physical activity? In your Braunwald textbook of medicine, physical activity is defined as any body movement for which caloric expenditure is there. Okay, so if I stand up and I sit down, that's physical activity. If I leave this room and go to the washroom and come back, that's physical activity. So anything we do, whether it's 1 step or 20 steps, is physical activity. And it's important to get in a lot of physical activity in the day. In fact, they say you should try and get in 10,000 steps. So I monitor my own. So if you can see out here, this is the other way around I'm showing you. So right now, today, I've done around 5,200 steps, and this is not counting my morning run. So the idea is to try and get in 10,000 steps in a day. So you must be physically active. In addition, it's important to try and get in some exercise. Now, exercise can be defined as structured physical activity. So, for example, if I take a 5-minute walk from my home to the railway station, that will be physical activity. But if that was, say, 25 minutes away and I walked briskly, that would be exercise. So, being physically active throughout the day has got benefits. And in addition, exercising or walking briskly for 30 to 40 minutes is beneficial. So, both should be done. Typically, in our patients, we see two types of people. One is the white-collar worker who spends most of the day doing nothing. They have people at home to do their work. They have secretaries in their office. They've got peons in the office. And then they go to the gym for an hour and feel very happy. On the other hand, we have the blue-collar workers who may wake up early in the morning. They do a lot of their housework. They walk long distances to reach their work. And the whole day they're very active, but they don't do any structured exercise. So if you have a combination of both, that would be the best. I hope that answers your question.
Doctor, the next question is by Dr. Ishad Malik. The question is, sir, do you think that every person before starting exercise should undergo an ECG to rule out any abnormality or probability of any cardiac risk?
Okay, thank you, doctor. So the question was, should every person undergoing exercise or starting with exercise, should they undergo an ECG? Honestly, I don't think every person needs to. The decision should be based on two factors. Number one, what's the clinical and medical background of the person? So a 25-year-old person with no coronary artery disease risk factors is very different from, say, a 55-year-old person with 4 risk factors. So typically, if the person's under 35 without risk factors, I don't think it's necessary. But if the person's above 35 and or they've got risk factors, yes, I think it's a good idea to at least get an ECG. Get a basic history. Family history is very important to ask. Do they smoke or not is very important to ask. A basic blood pressure and cholesterol and sugar. If we just do a simple blood test with cholesterol, sugar, weight of the person, ECG, smoking status, family history, we already have a good picture. And if there is at a higher risk, then yes, you should do an ECG, maybe even a stress test if they're going to do vigorous exercise.
Okay, doctor. The next question is by Vikas Singh. The question is, there are two extremes of cardiac patients. One very positive in terms of their outcomes, and the others feeling hopeless most of the times, even after repeated reassurances. How should we go about with rehab within them, and any gross changes?
Okay, so this is again an interesting question, which is that there are two types of patients. There's one type who gets who are very positive and they, whatever you tell them they do and they got a positive outlook, and the other who gets very depressed. So I'm sure you know that between heart disease and depression, there's a very strong two-way link. So we know that heart disease tends to cause depression, and we also know that depression is a risk factor for heart disease. Now, one very interesting thing is when a patient comes to rehab, what happens is they see other patients. And when they see other patients who had the same problem that they've had and now they're doing so well, it's an amazing boost. That does more to their confidence than anything you and I can tell them. So often I see patients coming in on the first day, second day, and they see somebody else, running on the treadmill, and they say, he's also a heart disease patient. How is that possible? I said, yes, he is. And you will be like that in maybe in 7 to 8 to 10 weeks. And that gives them much more confidence than what you and I can tell them. Also, when they start doing things and they start realizing that it's not as bad, that's a great benefit. So one of the best, if I may use the word, side effects of cardiac rehab, of exercise, is that the patient gets tremendous confidence. The other thing we do is there's a very simple screening questionnaire called PHQ. I think it's called PHQ, stands for Patient Health Questionnaire 2, and a PHQ 9. If you just Google PHQ 2, it's available on the net, and it's just two simple questions. How many days have you felt down in the past week? So if the person answers yes, then they may be at a higher risk of depression or anxiety. And then it's also good to involve a mental health professional. I know that we feel somehow hesitant in getting the psychologist, psychiatrist involved, but in our program, we have an in-house psychologist. So every patient, not just the ones whom we pick up something, has at least one informal meeting with a psychologist. So I think just talking to them, getting them involved, showing them other case studies of people who are doing well is the best way to motivate them.
Doctor, the next question is it possible to have cardiac rehabilitation in rural areas in present situation?
So the answer, the question, if I can repeat, can we have cardiac rehab in rural areas? And the answer is absolutely yes. We can modify. Today there is something they call ASHA workers. I work closely with Dr. Srinath Reddy, head of the president of the Public Health Foundation of India, and they're training people all over the country. They have a small little computer which they go around from village to village. They can take the ECG of the person. You can train community healthcare workers. What I didn't mention, and I'm glad this topic has come up, as part of the ICCPR. So the ICCPR, which I'm the vice chairman of, consists of about 30 countries. And we have developed, which we've launched today, and I'm the one who's led that process, a basic certification in cardiac rehab, which I encourage maybe some of you all or even your staff to take it. It's 8 modules, and we've got doctors from all over the world, 8 different countries who collaborated, which talk about very, very basic principles. So one can do that, one can get certified, and then whether it's a rural setting, a semi-rural or semi-urban setting, or a city, we can certainly implement it. Why not? It's just a question of knowing how to approach the risk factor reduction and secondary prevention for the patient.
The next question is, when to start exercise after acute MI?
Okay, so again, we've answered something similar earlier. Now, when you say when do you start exercise after an acute MI, one of the things also would be what is the other pre-morbid condition of the patient? So is it something that does the patient have a lot of diabetes? Do they have chronic kidney disease? But otherwise, in general, if we term exercise as any movement, so example, simple walking is exercise. Okay, if you're talking about just simple walking, I would say maybe even, like I said earlier, the moment the patient is stabilized, and that could mean walking 2 minutes, 3 minutes. And the simple rule of thumb is start with 5 minutes, and every week increase the time by 5 minutes. So in other words, in about 6 weeks, the patient should be able to walk 30 minutes. So after an MI, once they're stabilized, they can start walking 3, 4, 5 minutes almost immediately. For 1 week, walk 5 minutes, second week, 10 minutes, third week, 15 minutes, and so on and so forth.
Doctor, the next question is, a diabetic patient with severe diabetic neuropathy, what kind of exercise can you suggest? Is it walking or sprint? This is asked by Dr. Vamsi Tirupati.
Okay, so Dr. Vamsi, in terms of diabetes, you said is walking better or is sprinting better? Is that the question?
Yes, that's right.
So when a person is sprinting, that is high intensity exercise. And what's interesting is today in the world of research, they're looking more and more at this concept of high intensity exercise, or they call it HIIT, high intensity interval training, HIIT. Now, high intensity training, like sprinting, like pushing themselves fast for just a few minutes, then resting, pushing fast for a few minutes and resting, has shown to be beneficial, but we need to pick the correct patients. If the patient is not used to exercise and they suddenly start sprinting, bad things can happen to them cardiovascularly as well as musculoskeletally. So I would start with having everybody on a simple, low intensity, moderate intensity program, at least for a few weeks or a few months. Once they're ready, then we can go on to the next step and look at high intensity training, such as sprinting, in selected patients.
Doctor, the next question is, instead of ECG, 2D echo, is it better to see cardiac function?
Um, Instead of ECG, should you do a 2D echo, or instead of a ECG and a cardiac and a echo, do you do a functional test? So I'm not sure what the question is, but let me try and answer it this way. So an ECG is a fairly routine and a basic test. A 2D echo has a benefit in looking at the heart ejection fraction as well as looking at the valve. So 2D echo is useful. A stress test is a great functional test. So what the functional test tells you is when the person's exerting, exercising, putting their heart under stress, how does it respond? So the information you get from a stress test or a thallium test is very different from the information you get from an angiography. So an angiography is more a structural test. It's an anatomical test. You can look at the structure of the artery, you can look at inside the artery, but you don't see the function. So the information you get from a thallium test or a stress test and an angiography is very different, or an ECG or an echo is very different. So depending on the person and depending what you need to select the correct test. Sometimes we do all of them on the patient depending on the situation.
Doctor, the next question is by Dr. Harbans Goyal. The question is, a patient of severe osteoarthritis of knees, how can he take the CR or cardiac rehab?
Okay, so Dr. Goel, this is again a question which is asked often, that if somebody's got severe osteoarthritis of the knee, how do they do cardiac rehab? And here is my first response. Now, when we again talk about osteoarthritis, there are people who have osteoarthritis of the knee, which means that their knees hurt if they walk for 30 minutes. Some people's knees they start hurting on 20 minutes of walking. Some have a 10-minute limit, some have a 5-minute limit, and some can't walk at all. So if your patient's not able to walk at all, and their osteoarthritis is so severe, then they probably need a knee replacement. But otherwise, they can try what I call non-weight bearing exercise. So such as cycling. Often people whose knees hurt on walking, if they're on a cycle, because in a cycle the weight of your body is on the cycle, it's not on your knees. When you walk, they're on your knees. If a person has access to water and they're able to walk in water or swim, then that's an excellent form of exercise. But everybody doesn't have access to a pool, everybody doesn't know how to swim, so they may not be able to. But water exercise or even cycling may be kinder on the knee rather than walking. Also, supposing the patient can walk 15 minutes, then let them walk 15 minutes twice a day, once in the morning and once in the evening, rather than half an hour at one stretch. So that's another way of being able to do it.
Doctor, the next question is by Dr. Avdesh Khare. The question is, when exercise can be started in unstable angina patients who were discharged from hospital today?
Okay. So Dr. Khare, actually, the question is about unstable angina. Unstable angina is a contraindication for exercise. So if a patient has unstable angina, which means they have angina even at rest, or a very unpredictable pattern of angina, we technically call that as part of ACS, and such a patient should not exercise till that is taken care of, till that is stabilized. Patients with stable angina, whom we feel are otherwise okay, you can exercise, but they should be exercising below that anginal threshold. So typically patients with stable angina get their angina at a predictable rate pressure product. So if their heart, the rate pressure product is their heart rate into the systolic blood pressure. So if we know that typically when their heart rate touches 120, 130, or when their systolic pressure is more than 160, they start getting angina. We must keep that exercise threshold at least 10 minutes below, or rather 10 beats below the level at which they get angina. So they can exercise, but with appropriate precaution and supervision.
Okay. Doctor, the next question is by Dr. Sulok Desai. The question is, what is your opinion about EECP treatment, as somebody in market has published it much more?
Okay, so Dr. Desai's question is on EECP, which stands for Enhanced External Counterpulsation. So in my previous institute, when I was there at the Asian Art Institute, we did use EECP, but the cases need to be selected correctly. So the two big indications for EECP are for stable angina patients who have angina even after optimal therapy. And second is patients with stable heart failure. So in such patients, EECP has shown to be helpful. In fact, ironically, EECP has an exercise-like effect. So if a person is undergoing EECP, they should also be exercising. However, in several places, EECP is marketed as a complete alternative to a bypass surgery or an angioplasty. That's not the case. So an ECP is not right for each and every patient with coronary artery disease, but in certain selected groups, it can be helpful.
Okay. The next question is by Hemant Shanmugam. The question is, how good is our present day registry maintained in our hospitals for post-MI or post-CABG patients who have undergone rehab, and how best can registry be put to use? If so, can we put that registry at our national level education for both doctors and patients?
I think, Dr. Hemant, that's an absolutely excellent question and a suggestion. As far as I'm aware, and I could be wrong, but as far as I am aware, I don't think that there is a good national registry of cardiac rehab. I know in my last 17 years of working, I've tried to maintain as much data as I can, but I'm not aware of a national registry. I think it should be implemented. I hope that the Cardiological Society of India, because they have the resources and the ability, takes up the initiative to maintain the national registry, and I would be extremely happy to be an active part of it. But I think that's a necessary step we need to take for our country.
Okay, the next question is by Vikas Karwasara. The question is, sir, if patient is having very low ejection fraction, then what exercise can be advised?
So Dr. Vikas, your question is, if a person has low ejection fraction, what about exercise? So let me give you just a very rough guidelines related to ejection fraction. So firstly, if the normal ejection fraction we know is about 55 plus. So if somebody's got it between 45 and 55, honestly, I would treat that person pretty much like a person who's got 55 or higher. If somebody is between 35 and 45, if they're not symptomatic, they haven't gone into heart failure episodes, then again, I would be tempted to treat them pretty much similar to normal ejection fraction patients, except let's say if I took 6 weeks to get a regular EF person to say 30 to 45 minutes of walking, for this person who's between 35 and 45, I may take 8 weeks instead of 6 weeks. For somebody who's 25 to 35, I would monitor them more closely for arrhythmias. Again, I would progress them, but maybe again 10% slower. I would proactively look for signs and symptoms, educate them on fluid consumption, on diuretic usage, on beta blockers usage, to check their weight regularly, to check for fluid retention, not to have excess salt in their diet. But again, honestly, I've about a third of the patients I see have ejection fraction below 35%, and really they're able to do pretty much as well as the other patients. If it's below 25 or below 20, then again I would not disallow them to exercise, but I would just monitor it very closely. They often tend to have very low blood pressure as well. Again, sometimes because of all the medication they're on, their responses to exercise may not be that normal, but we need to monitor it. But please, just based on the ejection fraction, there will not be a criteria to rule a person out from exercising. It may be at a lower level, but they certainly can exercise. The lowest I've seen is 10%, and we've exercised that person. 15%, I must have come across at least 200 people, and we made them exercise at a lower level. And 15 to 25%, we've probably seen hundreds of patients, and they really haven't had any specific problems. In fact, in heart failure patients also, not only have they done a study on exercise called HF Action, they've also done studies on high intensity exercise in heart failure patients, and when done correctly was very effective and safe. That's not what I recommend right now to do high intensity, but the point I'm making is that they certainly can exercise.
The next question is by Amit Sinkar, and the question is, if a patient has stable angina and he does not want angiography, will limited supervised exercise help in improving their exercise tolerance? If yes, what should be the protocol?
Okay, so Dr. Amit, now this is an interesting but a difficult question to answer straight away. Now, when you say a person does not want an angiography, do they not want an angiography or do they not want an angioplasty? Because an angiography is a diagnostic test, and I encourage the patient to do it. If they don't agree to that, at least ask them to do a stress echo or a stress thallium so we can quantify the amount of dysfunction that the person, or the amount of compromised blood supply. If they've got a very stable angina pattern, I would say let them start exercising at a moderate level and optimize their anti-anginal medication.
Doctor, the next question is by Rajesh Pandey. The question is, what basic infrastructure is required for cardiac rehab set up in a hospital?
So in a hospital, it would be good to have a monitoring system. Some way we could monitor the ECG. It would be good to, of course, have your basic blood pressures and sugar measurement and all of that. Nice to have some amount of cardiovascular exercise equipment, such as a treadmill or such as a cycle, and nice to have a small amount of weights available as well. These are the basic minimum that you should have, and that would be nice to have. Of course, if you don't have this, doesn't mean you can't start it. But again, if you're a hospital setting, it would be nice to have some of this.
Doctor, the next question is by Vikas Karvasara. And the question is, sir, any journal or link from your institute that can educate us from time to time or very easily accessible to us online?
Okay, so as part of the association I'm talking about, the ICCPR, International Council of Cardiovascular Prevention and Rehabilitation, there is our website which I maintain is called globalcardiacrehab.com, where we put up regular newsletters of our member associations. So typically the Canadian Association, the American and the British, they have a newsletter that comes out roughly once every 3 months. So we put up those newsletters online, which is available for free download and free reading. Today, in fact, let me pull this out. USV has come up with some really nice booklets on cardiac rehabilitation, their educational series. So this is one of them that I'm holding. It says inpatients post-revascularization. This is the guideline. This is another one they've come out with, cardiac rehabilitation for heart failure patients. This is useful. Patients post myocardial infarction, and how to set up the center. So I think that this is useful, and you could ask the USV representative who's helping you to get your copy, and I'm sure they'll be more than happy to get that for you.
So the next question is, can we give aspirin after age of 65 years for prevention of CAD?
Okay, so aspirin as a routine drug for prevention of coronary artery disease is not recommended. In very high risk patients, on a case to case basis, you can decide. But remember, when the person's over 65, they're also at higher risk of gastrointestinal and cerebral bleeding. So I would weigh the risk of bleeding versus the risk of coronary artery disease, but I would not use it as a routine of care just because someone's over 65.
Doctor, the last question is, sir, for membership for your society, what is the process?
So, in terms of for this is actually a coalition of associations for different parts of the world. I think a simple thing is if you write me an email, I'll try and help you out. My email is ascontractor@gmail.com. A for apple, S for sugar, contractor, CONTRACTOR @gmail.com. And I'm more than happy to help you. Or I'm on Twitter. My Twitter ID is Dr. Contractor, DR Contractor. And on Facebook, my Facebook page is called The Heart Truth, which is the name of my book. It's The Heart Truth. So once again, it's 6 o'clock. It's been wonderful chatting with you. I wish I could see your faces. Unfortunately, I'm just looking at my face on the screen. That's the only negative part of this. If I could see your faces, that would be a lot better. Thank you very much for coming, for asking all your questions, for making this interactive. I found it most enjoyable, and I hope you enjoyed it too. So thank you, and thank you to USV. Thank you very much for organizing all of this, taking the time, trouble, and effort. And thanks to my IT team at the Sir H.N. Reliance Foundation Hospital for also helping me, and to the hospital for providing all the support for this. So thank you very much.
Thank you, doctor.
Thank you.